So hello all, just a quick few words from me. My name's Harriet Smith. I'm from Yorkshire and Humber Academic Health Science Network, and I am the workstream lead for Inequalities and the MedTech Funding Mandate lead for Spectra Optia. So welcome to this session. I'm just going to do a few housekeeping things first before we roll on. So next slide, please. Welcome, thank you for enrolling. We've put you all on mute, I'm afraid. There's 115 people coming to the session, so we thought it would be easier to mute everybody. The session also will be recorded, so we can send it to those of you who can't attend today. Also, please use the chat to ask questions, and we're more than willing to try and answer as many as we can during the session. And we've got a question and answer session at the end. We've put 20 minutes in for this question and answer session. So please raise your virtual hand and we will try and answer as much as we can at the end of the day. We'll try and theme some of the questions. If we can't get back in touch with you during this session, we'll pull them all into a frequently asked questions and we'll get those to you at the end of the session as well. So nothing silly, please put it in the chat and we will get back to you. So here's our agenda for the next hour. We've got quite a lot to cover. We've consciously left that 20 minutes at the end just so that we can have a really good question and answer and discussion session. There has been such a lot happening in the world of sickle cell treatment and Spectra Optia and MedTech Funding Mandate in the last year. So I'm sure that there will be no shortage of things for us to talk about. But I will pass over now to Katie Cusack for our first presentation. So over to you, Katie.
Thank you. Hello, everyone. So my name is Katie Cusack. So I work in the National Specialised Commissioning team, and I'm just going to give you a very brief update on some of the work going on nationally around sickle cell and inequalities, just as a bit of context for the rest of this webinar. Next slide, please, Graham. So there's a number of different strands of work that have been or in progress or have been taken forward over the last year. So obviously there was the publication last year of the which year are we on? But obviously No One's Listening report from the all-party parliamentary group. And following the publication of that report, obviously within NHS England, there's been ongoing work looking at the findings within the report and how we need to kind of take account of those going forward in terms of the way that we commission sickle cell services. We launched the national campaign, which everyone will have seen, which is Can you tell it's sickle cell, which I think has been really widely disseminated and welcomed by various stakeholders. There was the e-learning module launched around addressing inequalities in healthcare. And then more recently, which is the main thing I wanted to update you on, there's actually been a piece of work led by the NHS England Inequalities team looking at mapping the end-to-end care pathways for sickle cell. Next slide, please. So this is like really a rapid review work, really, that's been put in place, recognising the inequalities that have been within the pathway that have been highlighted by various bits of work, including the No One's Listening report. So what's happened is that NHS England launched this review led by the Inequalities team, and really the purpose of it was to map the entire end-to-end pathway for patients with sickle cell disease to identify kind of gaps in that pathway now, and also potential improvements we can make to the pathway, including thinking about new levers that we can be implemented, new actions that could be implemented to address the gaps that have been identified in the pathway. So over the summer, there were a number of kind of work stream meetings called together, which mapped out the pathways. But ultimately, which I'll talk about a bit more in a minute, but ultimately the output of this task and finish group is that a report will be produced which really sets out, I guess, those gaps in the pathway that have been identified and make some recommendations as to the work that can be undertaken to address those. As part of the report, it will pick up the kind of formal NHS England's response to the No One's Listening report. So it's all being brought together in this piece of work. And then the report will kind of go to the Equalities group in NHS England, and there'll be some work coming out in early next year around recommendations on the back of the report, and us needing to work with all of our stakeholders for implementing those over the coming months. Someone can just put themselves on mute because I'm getting quite a lot of background feed. Thank you. Next slide, please. So as I said, as part of this piece of work, this rapid piece of work, over July and August, 4 work streams were established. So the first work stream was looking at preconception, antenatal, newborn and maternity pathways. The second one, primary care, community, personalised care, palliative and end-of-life care. And the third one, urgent and emergency care and ambulance. And the fourth one, which myself and my colleague Zoe, who's on the call, is very heavily involved with, was the secondary and tertiary care. And within that secondary and tertiary care pathway, we split it up into adult, children's and specialised care. So over the summer, we basically pulled together a small group of stakeholders, and we mapped those pathways across secondary and tertiary care from end to end. And the same piece of work was done in those other 3 work streams, and we have all of those mapped now, and ultimately all of the gaps within the pathways were kind of identified. Next slide, please. So the outputs for each of the work stream we were asked to produce was a description of the optimal pathway for patients, a kind of comparison with what we think is currently the current pathways for patients and where those gaps and challenges are. We were asked to make some recommendations for actions that could be taken to address the gaps and challenges. In thinking about gaps, we did consider a range of different gaps, including access to research, issues with data. It was a kind of very broad remit. We weren't narrowing ourselves to anything in particular. And then, as I said, we were asked to kind of put forward recommendations from each work stream. Next slide, please. So this quite busy slide is basically pulling together all of the gaps that have come out of all the different work streams. So there's a load of detail that goes underneath this, but I just wanted to include it as kind of, it shows, I think, the breadth of the mapping exercise that happened, and how, and just kind of nicely present some of the issues that are on there. So I guess my key point is that's all been mapped, all the 4 pathways have been mapped together, all the gaps and challenges from the end-to-end pathway have been identified, and the next steps now are to look at the recommendations and actions that within NHS England we'd want to kind of take forward with our stakeholders going forward. So I think I just wanted to highlight that there's quite a lot of attention, work going on nationally around sickle cell pathways, around inequalities issues, and that you should look out for kind of more learning, more work, more outputs coming out from us in after Christmas to support, to take forward the work that I've just described now. Just last slide then, please, Graham. So the other thing I just wanted to quickly flag is that we will, as part of this learning and actions and recommendations within specialised commissioning, we will be shortly launching a compliance exercise against the specifications for SHTs and HCCs and the NHP. That will be coming out hopefully in the next couple of weeks for completion during October and November. Really the outputs of that exercise will inform future service specification revisions or contracting work, and that is part of this bigger picture. So we're not looking things at isolation. We'll also then link that back with the other bits of work we're doing nationally around responding to the APPG report and also the learnings from the pathway review. I will stop now because I think I've probably gone over my time, but I'll stop now.
Thank you, Katie. That's really interesting. Loads to absorb. I'll now hand over to Sarah Tyers from NHS England to talk about the MedTech Funding Mandate policy.
Thanks, Harriet. So hi, I'm Sarah Tyers and I work in the Innovation, Research and Life Sciences team at NHS England. And one of the policies that we look after is the MedTech Funding Mandate policy. I'm going to talk a little bit about it in its broad terms and how we came to work with Spectra, Optia and Sickle for automated red cell exchange for sickle cell patients. So if I could have my first slide, please, Graham. So what is the MedTech Funding Mandate? Well, in April 2021, this policy was launched, and it aims to get technologies to patients faster. It's part of the long-term plan commitment, and it's to ensure that healthcare providers are enabled, are aware of the cost-saving technologies that NICE approve, with potential cash or resource benefits to using those, and the implementation support is with the Academic Health Science Network. So we work centrally to understand products, and then the Academic Health Science Network help us in their local communities to get those implemented. So the next slide, please, Graham. So what does the policy aim to achieve? So it wants to direct the NHS on those medtech innovations that are effective and cost saving. And we do this to increase the spread and adoption. We mandate the commissioners to fund the supported technologies. And we hope that this ensures equity of provision and support the NHS to develop a sustainable approach to innovation adoption. Next slide, please. So the work over the last few years in the Innovation Research and Life Sciences team has helped us learn about the barriers and enablers of implementing innovation. And this policy helps overcome some of the main barriers that we've learnt about. The first one being the payment mechanism. So the policy mandates commissioners to fund the cost of technologies on top of tariff payments or fixed agreements, and that's all laid out in the tariff workbooks. It helps procurement barriers too. So procurement is very complex in the NHS, and we try to ensure that the technologies are available to procure on NHS supply chain where possible. Project management and implementation management is also a difficult area of implementation of innovation. And again, our partners, the Academic Health Science Network, is on hand to help with this for any of the supported technologies. And we would like to ensure equitable patient access, so making sure there's fair access across the whole of NHS and not just pockets of innovative work, so that all patients who are eligible can access these technologies. Next slide, please, Graham. So in order for us to support technologies effectively, they do have to meet a criteria. So the product selection criteria for technologies to be supported by the MedTech Funding Mandate is that they have to be effective, and that's demonstrated through NICE guidance. The NICE guidance we look at is MTG guidance, which is medical technology guidance, or diagnostic guidance, DG guidance. And what we look for in published NICE guidance is that the technologies themselves are cost saving within 3 years. So by investing in the technologies, they deliver savings of value within those 3 years. And that can be cost savings, so cash releasing savings, but mainly it's normally resources that are saved and that can be used for other things. The technologies have to be affordable to the NHS. So the cost impact can't exceed £20 million in any of the first 3 years for the whole NHS to adopt those technologies. And we assess the technologies on an ongoing basis, and normally sort of a cut-off point is around the end of June for technologies to be assessed for the following year. So next slide, please. So this slide shows the the 11 technologies that we currently support, and as you can see, Spectra Optia is one of them. So we support various technologies that do lots of different things. 4 of them help BPH patients. We have a digital chest drain system, HeartFlow, which is a value-added CT technology, SecureCath, which helps to secure PICC lines in place without the use of adhesives. GammaCore is a technology which helps cluster headaches, and placental growth factor helps to rule out preeclampsia in pregnant ladies. So we support a range of technologies, and Spectra Optia is the one that we're focusing on today. So next slide, please. As you've heard today, this session is being led by Harriet, and each of the technologies has an AHSN lead, which takes the lead in understanding how these technologies are already used in the NHS and what work is needed to make sure that that's diffused into the entire NHS. And then the rest of the NHS networks support that work, which is led by the AHSN lead. Next slide, please. And there's a slide at the end. So when these slides are sent out, please feel free to contact us. We have a Futures NHS page, which has information about the policy and any developments and the technologies we support, as well as links to the guidance. And I think that's all from me, Harriet.
That's great, Sarah. Thank you. Okay, next we have Justine from Specialised Commissioning, who's going to tell us about the money aspect of it and the business cases.
Hi everyone, my name's Justine and I'm Deputy Director of Finance for Specialised Commissioning, and I have had the pleasure of working with a group to take this forward. Next slide, please. So the background to this is Sarah actually contacted me. I checked back and it was back in July 21 and asked if she thought Spectra Optia might be linked to specialised commissioning, so would we support the adoption of the technology? So I then took it to our programme of care lead, Zoe, and we discussed it with our CRG lead for hemoglobinopathies, and the feedback was that we would definitely like to support the technology. So the first thing we had to do is really understand the MFTM, because this was the first MFTM product that was specialised commissioning. So we didn't really know too much about the policy or the mandate and what it meant. And we also needed to understand Spectra Optia technology and what it was and how much would it cost and everything to fund. So what's really important in how we've developed this is that the policy mandates commissioners to fund the technologies, which is really important. And that helps us because it means that actually we do need to do something. And that's set out in the payment system. But what's really important is it's the fundamental principles of the policy, which are the most important to understand. And that's important to think about when you think about how we've developed what we have. Next slide, please. So the first thing we did is undertake some analysis. So we looked at the NICE technology impact assessment and the resource impact, which is you just download it off NICE, so it's all there. And what it told me was that the machine and the exchange software is about 62,000. So the first thing I went is, it's capital, right? That's the problem. And then you've got maintenance, you've got units of red cells, consumables. So not something you can just kind of order off of supply chain. The next thing we did is we looked at what had happened in the past. So we've already had a sequin back in 16-17, which incentivized at £420 per automated red cell exchange with a target of 95%. So we've had, and that was done prior to setting up a new tariff. So that was brought in to get something going. Then in 1920, 2 new HRGs were introduced. so we had, before we just had one which included single plasma exchange, and it was all in together, and then it split out. And you can see SC41 was given a much higher tariff, and that's the automated compared to the manual. But as you go along, you'll see that they've come closer now, because, and the reason for that is that basically it's done the job. So when you look at the activity, the sequin and the national tariff have actually had the desired impact. And when you look at the activity, most providers are actually doing automated cell exchange now. Next slide, please. So what we found is that the Spectra Optia technology is very different to other technologies in that it's not a discrete product that you can order. We don't fund capital. So that was another thing, which is right, okay. And we've already made significant changes to the policies, national tariff policy and sequin, and its work. So why have we still got a problem, and what was next? So what we did is we brought together a cross-organisation working party chaired by Harriet, which is very helpful. And we've got various people, so myself, the commissioners, my colleagues in the commissioning team, NHSBT, and we came together to kind of work through, well, what are the issues? And very quickly we came up and found that there are two clear issues. One is out of hours provision, because it's just not cost effective to run as an add-on to an in-hour service, and provision to the small but very increasing populations outside of large cities who are having to travel a long way. So they're the first two things we found. They might not be, I'm sure they're not going to be the only two things, but they were two of the key things that we found. As part of that group, it came to our attention that there were two business cases that had been kind of bouncing around the system. One was in Manchester and one was in London, but there wasn't any funding. So the business cases were really good. They'd already been developed, and we kind of said, well, actually, why don't we bring them here, have a look at them, because at this point we hadn't seen them, and just see if a business case approach might be a good way to actually target funding into the exact areas that we want to improve and the areas that are causing the issues. So next slide, please. So despite us only setting the group up in June 22, so pretty well, not that long ago really, the pilot and the two business cases have proven to be a real success. So we've actually provided funding already, because they proved cost effectiveness. They'd already been written, and we wanted to kind of get things up and running. So basically, we thought at the start of this, I thought at the start of this, I would be funding products that were going to be ordered from NHS supply chain. So what we did is we've just said, look, let's just use the funding that we were going to use in a different way to fund the business cases. So we're just using the same sort of source of funding. So basically, we've come up and said there are four key principles to access funding. One, the business case must have the full support of the trust. The local specialised haemoglobinopathy, I can't say SHT, the haemoglobinopathy coordinating centre, and the regional team stroke ICB. So we're in kind of delegation and sort of that pathway, so it's really important to bring the ICB in along with the regional team. So it must have full support. Secondly, the funding can only be used for Spectra, Optia or automated red cell exchange. So we want to future-proof this by not limiting it to one product. So if there were new products that came in, it's trust choice. We're not going to say it has to be one product, because NICE might review and make a different recommendation. So but it can only be used for the use of automated red cell exchange. Funding must provide a stepped improvement in access for patients over and above the current service. So when we're talking about that, we're talking about the baseline of funding has been reset in 1920. So it's really important we're looking for that the funding makes a change and supports a real change for patients. And it must demonstrate value for money. So what we found is just extending an in-house service to an out-of-hours service would potentially be not cost effective. So we really need to demonstrate that it's really cost effective to do this. So there's not going to be a standard format for business cases. So basically trusts can just use their own formats. So if they've already got business cases that they've been working out, that's absolutely fine. But what we need to understand is a clear analysis of what the issue is. What are we trying to address? We need a fully costed option appraisal with a recommended approach. Now that might be 2 or 3 options, just looking at what could have been done, and then what is the recommendation approach and why that recommended approach is the most clinical and cost effective. Next slide, please. So whilst we are still very early days, we want to get things up and running. So we don't want to wait for everybody to get their business cases in. We want to get them up and running so patients can get access as quickly as possible. So any existing provider of sickle cell services may submit a business case. It's not limited to any particular one. It's all about improving equality and access to services, and this is absolutely key. So the business cases really must demonstrate that. We can't fund capital, so if there's a capital need for a new piece of equipment, then that must be met locally, and we'd need to understand that. But we could meet any additional capital charges or the revenue costs associated with that. It is for stepped improvements from the current level of care and isn't to fund perceived or actual historic funding gaps. That's really important. We want this money to make a difference. So the funding is recurrent. So once it's agreed, that will roll forward and will be recurrent. But we could also refund non-recurrent things if that's also wanted. And we'll keep the central budget under continual review. So we haven't, because we're in such early days, we don't have a fixed budget. This is coming out of our massive device budget, and is something we had ring fenced to when we knew this was coming forward to support. But we will keep that under review as we start to see the business cases come through. And then part of the one of the things we'll ask for is feedback from regions and the HCC once confirming the business case has been implemented, and any learning points from that. So the MedTech Funding Mandate for me is really, really important. So it's how can we implement those in future. So this is a really different way of doing things, because we couldn't do what we thought we were going to do. So that's where we are. That's me done, Harriet.
That's amazing, Justine. Thank you. And now we're honoured because we've got Dr. Joseph Sheriff from Manchester Hospitals also to speak to us now. He's going to tell you a little bit about the Manchester pilot site and the things that they did in order to secure funding. So welcome, Joseph.
Thank you very much. Yes, so sorry, I don't have any slides. I was just going to tell you very briefly about our service in Manchester. So I was appointed here in 2019. And one of the obvious issues in our service was the lack of 24-hour access to automated red cell exchange. We do have in-house apheresis within working hours, and if any emergency red cell exchanges are required within hours, it's available. However, out of hours, we just didn't have a service, which means usually the haematology registrar would have to do a manual red cell exchange, and this can have a big impact on the clinical service as well. So we have approximately 450 patients here in Manchester, and they live across the region in Greater Manchester, and they can present to any of the local hospitals with acute complications. If they present with acute stroke, they usually go to one of the other trusts within the region. And none of the other sites within the region, as they're not specialist centres, have any access at all to automated red cell exchange in hours or out of hours. And so patients presenting with acute chest syndrome or stroke, they often call us for advice, and we would often advise them to do a manual exchange locally, which usually they're not experienced to do and causes a lot of issues as well. So I put forward our business case in 2020 to my trust, asking for funding for access to 24-hour red cell exchange. And because I'd spoke to other regions as well and asked how they did it, I'd also spoke to NHSBT, as I thought a service level agreement with them would be the most practical way to implement this, as they already have the infrastructure and expertise and already provide this service to other places in the country. So we worked out the costs based on the estimated number of routine and acute procedures per year. And NHSBT were quite clear that they were not able to provide the out of hours work alone, and also needed to take on some of the elective red cell exchange work in order to staff an on-call rota essentially. And after much delay with COVID and lots of stumbling blocks, we almost got to the stage of getting it signed off by finance, but it just kept coming up with constant barriers. And then our HCC network manager, who was helping me write the business case, took on a new role in the innovation team, and I think that's how we got linked in with the MedTech Funding Mandate and found out about this. And obviously we were delighted to find out that they could support our business case. So it has been successfully implemented as of this month, and I'll be working with our network manager and NHSBT to ensure we have pathways so that the trust within the region can access this service. So this provides reassurance for the clinical team that our patients will have access to this procedure no matter which hospital they present to within Greater Manchester. And they also are now taking on some of our routine work, which is very much welcomed as well. So very grateful to everyone on this call who's helped make this happen. Much appreciated.
That's great, thank you. Okay, so I expected a loads of questions in the chat here, but I was just wondering whether anybody does have any questions. Just please put your hands up and we'll try and negotiate our way around them as much as we can. Stella, would you like to go first?
Sorry, is it me, Stella Kotsiopoulou?
Yep, that'd be great.
Oh, hello,
I think you were first coming up.
Oh, wow, okay. Thank you very much. That is very interesting to see that the help and support with developing the business case. And now I note that obviously capital is not covered, understandably, but that would also represent a challenge when it comes to getting business cases approved by the trust. With the current climate of financial challenges, we hear of trusts only looking to support and back up cost neutral or revenue generating business cases, and that represents a major challenge for us because that stage of full trust approval and of course network approval, I understand, is required prior to then liaising with the MedTech Funding Mandate for further support. So I'd be grateful for your thoughts on that.
Right, Harry,
would you like to take that one?
Yeah, so the regions is about supporting the case. It's about saying, yes, this is something we would support. It obviously doesn't need to be cost neutral because there's funding that's coming from the national team. So we're not asking the business case to come in and say cost neutral. It's about demonstrating the cost effectiveness, i.e., the impact on the medical team. So it's not going to release cash without a doubt, but what we need is that cost effectiveness. But one thing we can't do is fund the equipment. But what we found is the example for both Manchester and the other one is that they were using the equipment that's already there. So it wasn't a capital issue actually that we were able to support. It was all revenue. So it's really stepping back and thinking, what do we need to do? So unfortunately, we can't fund capital because Speccom's a revenue, it's a revenue budget. And we don't have access to capital. That would need to come from the usual route, so your ICSs, and that's why the ICS is really important, because it's about the local population and then supporting that and then us meeting the revenue consequences.
Okay, that makes sense. Thank you very much.
Okay, Tuli Yegan.
Hello, thank you for this. I'm Tuli Yegan. I work in Lewisham Hospital. And just needed to briefly tell you about our country. I noticed that the mandate doesn't really cover staffing to operate equipments. And this is where we have come a cropper really with this. We're newly, like Stella's trust, we are one of 2 DGHs in the country, I think, who are specialist hemoglobinopathy teams. And in our hospital, we managed to get an Optia Spectra machine and to provide some apheresis. We got the full sequin, and then we got the tariff, which was very advantageous as we were trying to increase our practice. So it was based on about 12 patients a month, the tariff that we got and got stuck with after COVID and after everything went to block contracts. So now we are doing about 38 procedures a month, and we are getting paid for just 12. So, and there's potential for increase further. So we are completely stuck. We can't offer any more to the patients. We've diverted all staff who should be doing other things to this procedure because it's very important, very, very life-saving. But we would need some help to be paid for the number of procedures we're doing and for the extra consumables and so forth that we're using, which are at the moment in themselves causing a problem. And we need your help with this. Otherwise, you know, we did exactly what we were told. We increased our practice exactly as mandated. We offered it to a lot of people. And as a result of this, our service is about to collapse because we didn't get the appropriate financial support. So I would like to know how the MedTech mandate might be able to help us, please. Thank you.
So the baseline is 1920 because all trusts were reset. The funding for all trusts was reset. So any increase on 1920, expansion of services, even if you've already done that, but it's about to fall over. This isn't about we'll pay for each procedure. It's about saying we need X amount of staffing to fund this because we're moving away from tariffs, especially for non-elective, that it's kind of flat. So this is all about putting a business case together to say this is what we need to sustain our service and expand it and offer the service we need. So that's where the academic health service team can help with the business case. So, but we need to really understand your baseline, what your historic funding was, and it's moving from that point.
Okay, can I ask something else? We've got a business case in situ, and we've submitted it to the trust actually last week, and we may or may not be able to get the funding for it. We absolutely need some 2 apheresis nurses to operate this service. So what shall we do? Should we take the money from the trust and then the trust, you will reimburse the trust for this money?
No, so the business case needs to go through the trust to make sure that the trust are supportive of it, to say, yes, this is something we really want to do and support. And then it would come up through the HCC, they would your SHT HCC, they would sign it off and say yes, and then it would come to the national team so that we can consider it in the funding. So this is when we say sign off locally, it's about signing the support off for it to say if the funding came, yes, we'd absolutely support the implementation. So what we don't want to do is give funding out and then find that actually the trust didn't support the changes and the implementation of it. So it's just making sure that if we go and say with Manchester, it was really quick. It came through, the business case was already signed off by the trust. It had regional support and HCC support. So when it came to us, it was just, we went, yeah, this makes absolute sense. And I was able to hand over the money. So it's making sure that all of those things are in place before it gets to us so that we can say, yeah, and we'll be looking at value for money and things like that.
Thank you.
Okay, that's fabulous, Justine. Thank you. Dr. Tsatsikas?
Hi, thank you. It's Dimitris Etskas from London here. A few points I wanted to make about everything that has been said so far. Let me just start about the sequin in 2017. So, for example, that part, we've had huge problems with the cost of the procedure and covering the procedure. And when that sequin came about, at that point, we had calculated that the average cost of a procedure to the individual trust was in excess of the £1,200–1,300. So, and with the existing tariff then, every time we performed one procedure, the trust would make a loss of about £800–900. So the sequin meant it was something to incentivize, but actually what it really meant was that instead of making a big loss, you make a big loss still, just not as big. So that was a problem, and that I think has been the approach quite a lot. Another point is about the 24-hour apheresis service. my view is that at the moment, many centers across the country, if not all, are struggling to keep up with the demand for the routine procedures, the regular procedures. And if we count into that the support that specialist centers are supposed to provide to the local hemoglobinopathy teams, because that is something we talk about, but is not often done in practice. So my patients, where we are a specialist team, have a much easier way to get access to the procedure than local teams that are affiliated to us, but we cannot as easy access the intervention. So when it comes to out of hours exchange, that would be great if we could do everything. But I think the priority has to be to meet the needs for the regular exchange transfusions, the automated red cell exchange transfusions that exist. And that includes those who are looked after at specialist centers, but also the ones who are looked after elsewhere and have to have access. Because when it comes to out of hours, at the end of the day, it's not such a difficult thing to set up pathways in-house with our intensivists, with our medics, to actually perform out-of-hours manual exchanges, and they are just as effective. So the priority has to be to establish a robust service for routine red cell exchange transfusion for all patients who need it. And the final point is that when we talk about cost effectiveness, I am sometimes worried that we only see things that are very easily measurable. So, for example, if you go back to the NICE approval in 2016, the main thing that is mentioned is the reduction at the cost of iron chelating agents, so the avoidance of iron overload, which is a very easy to measure thing, but it's a very small part of the whole. We then showed that, and it was part of the NICE guideline then, but we have shown that you have a big reduction in the cost to the NHS, to the taxpayer, if you like, by reducing by a lot the number of unplanned admissions. But again, there are other benefits which are not that easily measurable. So we know that you improve the health of patients by this intervention, and you improve the long-term health of these patients. And conversely, by not doing so, that comes with a cost. Let me put it as an example. If you invest a large amount of money in an anti-smoking campaign, you actually are saving a lot of money because you prevent smoking-related diseases, and the cost to the NHS that those diseases will incur in the next year, 5 years, 10 years, and so on. So when we talk about cost efficiency, cost efficacy of the intervention, we have to think not only the things that are happening that are costly and will reduce, but how we can avoid costly things from happening in the future. And that's only talking from a financial point of view, let alone the benefit of the patient. That was it.
Some very good points. Any of the panel like to respond?
I was just going to say, Harriet, we just need to think this is a specific policy. This isn't the wider, sorting out the whole of the NHS. This is purely to support the MedTech mandate. So we had an option where we could have said we can't do this because we can't pay for machines and that it's a new machine. So we're doing something slightly different. So if patients haven't got access and they weren't getting, there's an increase needed to patient access from your 1920 financial baseline, then that is something we would support with a business case. But what so it doesn't really, the history was just there was a sequence, and we can see that for most people, the activity has swapped. You can absolutely see it. So whether or not it funded enough or not, it's kind of irrelevant now because we've changed the baseline through COVID and everything else. and trusts were funded. So what we're looking for is stepped improvements from 1920. That doesn't mean to say it has to be out of hours. They were just the ones that came up very quickly. So it may be every system may be different. So what we're looking for is what might work in one area, i.e. it was out of hours in Manchester. That may not be the case in another area. That's why we need these systems to come and tell us what we could do to help them improve automated red cell exchange.
Perfect. Thank you,
Can I
Justine.
just come in with a point in terms of manual red cell exchange, there is far more blood used and it's less effective than an automated. So, and I'm coming from the NHS blood and transplant, where we know that supply of blood could potentially be going into amber this week. So we do need to take everything into consideration, and it is, isn't more of an optimal treatment than a manual red cell exchange.
Thank you, Teresa. Sarah Stewart-Smith, you've been waiting very patiently.
Hi, I'm Sarah Stewart-Smith from King's College London, and it's embarrassing to say that in London, across our HCC, we don't have an out of hours red cell exchange programme, but I do think that that's something we need to work on. But also, we've got lots of patients who are eligible for red cell exchange who aren't receiving them, or people who are having suboptimal control because we've had to stretch their intervals too much. So I wanted to ask Dr. Josie Sharif a couple of questions. So when you were setting up your contract with NHSBT, which sounds very very good, are these done on site or in NH with the blood transfusion service, the actual procedures?
It's in our usual apheresis. So our day unit does. We have apheresis nurses already who do most of our routine service. So what NHSBT are going to do is just provide extra nurses and do some of our procedures. So they've agreed to do sort of 2 of our routine procedures per week.
Okay, I mean, that's interesting, but the problem with King's is that we've got a very crowded apheresis service that we share with neurology and stem cell transplants. So we lack the physical space to do our red cell exchanges. So even if we suddenly got another 4 nurses, we just couldn't have the physical space to do it in. So it'd be interesting to know if NHSBT ever do them off-site for the routine ones.
Sarah, I'm in discussion actually with neurology at King's about trying to take some of the neurology work to allow you.
That's what we've been hoping, yeah.
And we're also looking at potentially getting a nurse in a van to go out to other ambulatory areas, so not bringing every patient into the treatment centres, to try and share the load, because we've got the logistics within NHS blood and transplant to be able to do that. So we're looking at all different options to try and fix the gaps everywhere for the individual needs.
Because that's one of the other problems, is that although in theory we could eventually provide a more specialist service to support our local teams, the reality is that bed availability is such a problem that you can say, absolutely, yes, we'll take this patient from Medway or something. But then the reality is a bed is never allocated to them. So we can't.
Yeah.
And I mean, a nurse in a van to some extent will help with that. I suppose she'll turn up and do the apheresis locally.
Yeah. Yeah. And we're looking at potentially doing some elective work that way to try and outreach to areas with small numbers of patients, to then potentially, if we can in the future, also offer the 24/7 out of hours far afield as possible.
And in terms of
No, carry on.
I was just saying, in terms of setting up this sort of program with NHSBT, what sort of numbers of routine? You're saying just 2 a day that they do in order to provide their out of hours service.
It was just a week.
For 2 a week.
Yeah, it depends on the area, Sarah. So we've got to be able to ensure that we've got enough staff to provide that 24/7 care. So it depends on what other elective work is done in that area. So it will be individual, but the 2 we've looked at so far was just 2 a week. But because we already had services, tiny numbers, yeah.
It is, but we only have about 10% of our patients on red cell exchange, and I know it's probably quite different in London, but it's just, we have the same issues with capacity, and CAR-T and ECP all taking over the day unit. But with this NHSBT collaboration, I've not increased the number of patients going on red cell exchange. We've just got the extra staff in, so the day unit nurses can be a bit released to do other things as well.
Oh, okay. The other thing that I feel is slightly the elephant in the room is the eligibility for a red cell exchange transfusion program. So obviously it's always really simple when somebody's had a stroke and that they're, you know, got sickle vasculopathy. But I think what some other people are alluding to are the people that have very frequent pain crises and aren't for whatever reason eligible or responding to hydroxycarbamide. Sometimes it's harder to get on them on the programme, because actually the cost to savings to NHS are potentially massive, because we've got patients who've been in, you know, very repeatedly every month, and then they're on an exchange programme, they haven't come in for a year. We can certainly put that into a business plan. But does anyone have any thoughts about eligibility? It's just if the medical team treating them think they're eligible, or have you got any other criteria at NHS England that you're applying?
Can I answer that clinically?
Yes, please.
So Sarah, yeah, Sarah, I think that would be entirely dependent on the medical team.
No, I think it must be, but we've sometimes had some pushback from the apheresis team.
Yeah.
And it would just be nice to know that that is, you know, agreed at all levels, that it's the clinical team that are deciding that they're eligible.
Yeah, I mean, I think I've got not everybody nodding to that, what I've just said. So I think if the clinicians, I mean, I'm pretty sure that you would discuss that in your MDT within your department. And if that's been ratified within your department and as a clinical team, you decide that this patient is eligible for an exchange transfusion, then that would be the eligibility effectively.
No, that's perfect. Oh, that's all my points. Thank you very much. Thanks, Jo, for your answers.
Thank you very much for that. Kathy Brennan.
Hello, just trying to turn my camera on. It's misbehaving. You don't have the joys of seeing my face, I don't think. I'll try. Yeah, so basically, I work in London region. So my role at the moment is Deputy Director for Quality and Nursing, but I also have a role in commissioning, and particularly around haemoglobinopathies. So thank you, really helpful presentation, because I think for us, we're trying to understand this from a regional perspective with our 4 HCC networks, who obviously cover more widely than London. So they've got some centres in East of England, for example, South East region. It's not that we were holding back, we were waiting to hear more about this piece of work to then understand how we link together. So, for example, we had a meeting with Thule last week in terms of Lewisham and Greenwich and their provision. And what we would like to understand then is the process. So for us to work together with our ICB leads, obviously for this, to sign this off from a regional perspective, how you see that working. So we've been working with our networks. They've done some fantastic work highlighting where the challenges are and the gaps are for apheresis provision across their network. So I see us working together, obviously very closely with them, but yeah, just some guidance really on next steps going forwards. Because we're really keen to support this. And we've got some data that just shows use going through the roof. Lewisham and Greenwich is an example compared with 2019. Sorry, you can't see my face.
That's great. Any of the panel want to respond?
I'll probably just reiterate. Sorry.
I've stunned you all into silence.
Go on, Justine.
I was just going to say that I think it's probably us meeting with the London team to see how we take this forward. It might be easier to do that if you're looking pan-London.
Yeah.
We can certainly help. What we're not after is kind of a kind of really detailed 100-page business case. It needs to be short and succinct. But very happy to meet. It sounds like you've actually taken quite a few steps forward. So we just need to work out how do we put it on paper, if you like, and how and where that funding, how we can put, who's going to hold the funding, who's going to lead on it. So if it's across the South East and East of England, it doesn't really matter if it's for all the patients together attending those hospitals. But I suggest we kind of do something supporting you, maybe a call with the region and some of the team.
Yeah, I think that would be really helpful for obviously our HCC leads for the networks. That'd be brilliant.
That's fab, Kathy, and I think the AHSN will pick that up with you as well, and we'll try to pull everybody around the table quite quickly. I'm aware of some of these conversations that have been happening, so we should be able to move quite quickly with this.
Can I just add in there from the NHS blood and transplant point of view, we do have 16 whole-time equivalent apheresis nurses in London. we'll be moving to 2 nurses on call shortly for the central and the broader. I'm not quite sure how far afield our current nurses can go, but we can certainly explore that. But we do have 70 apheresis nurses across the country. So again, for other areas, not just London, happy to have those discussions. We just want to collaborate and reach the patients that are currently not able to access treatments.
Fabulous.
Okay, so I've got no more hands up, and I think we've managed to cover everything pretty much in the chat. Is there anything in the chat that I might have missed? If we have, then as I say, we'll pull something together and email it out to you all. When we send that email as well, we will send out the contact details for all your local regional AHSN leads. So if you feel like you want to engage in conversation with them, you will know how to contact them. And I'll also send out our information at yhahsn.com. So feel free to contact me as well, and we can coordinate anything going forward. Just one thing come up, was it? London meeting would be great. Yep, we'll definitely set that up. I think that's definitely one of our priorities for the near future. So thank you very much for attending. It's 1:27, so we've done very well considering I was worried about time at the start of all of this. But thank you very much, and we will be in touch going forward. Thank you for your time. Goodbye.
Thank you.
Thank you.
Thank you.
Thanks.
Bye.
Bye.
Thank you. Bye-bye.
Thank you.